Dear Pure Urology Facebook viewers, good evening one and all. Today topic is endoscopic combined intrarenal surgery, ECIRS. By this time, most of the young urologists, senior urologists are aware that supine PCNL plus combined with RIRS is endoscopic combined intrarenal surgery. Today's speaker is Dr. Vikram Sreedharan. Even though he is junior, he is very close friend of me. And he presented this talk in South Zone. I was impressed the number of the cases he has presented. That presentation was short and crisp. So I thought we will exchange our thoughts more detail in this forum. Dr. Vikram Sreedharan, actually an important point to mention is he works at Trichy as a team work. 4 of them are there along with him. My close friends are there. Vikram will tell about them, and they practice together, not in one hospital, their own hospitals. After that, whenever somebody is absent, the other one will cover the hospital. This creates a lot of quality of life. This is their uniqueness. One more thing is that when I went in 2019 or 18 to the same conference, I mentioned again and again that I watched Govindarajan sir doing supine PCNL around 8 cases in row. So then I thought, why not I try? I tried, and after that I picked up, and after last 3-4 years, I am almost doing only supine PCNL now. He is one of the team member, and he underwent training in laparoscopy. He is from the MCH from Sri Ramchandra Medical College, which is a well-known college in 2008, and underwent training in laparoscopic urology from Dr. George P. Abraham, consultant urologist at Sri Paduka Specialty Hospital, Trichy. And in fact, I want to share the screen so that it will be on record. So today topic is the ideal cases of ECIRS. A lot of people argue why you have to do ECIRS, why you have to learn supine PCNL, why you have to do RIRS for large stones. The answer is these cases. He has been an operating faculty in RIRS in several live operative workshops across the country. Founder member of Trichy Uro Education Foundation, True. It is a very good group through which live operative hands-on workshop on RIRS and supine PCNL were being conducted in 2014. They also started a fellowship program, True Endourology Fellowship Program. He also does under spinal anesthesia RIRS. He also does with different type of frequency and energy. Let us listen from him before going to the details. Thank you, Vikram. It is nice to have you on this forum. I hope the youngsters will get maximum benefit today. Let us start. Thank you once again. Over to you.
Thank you, sir. Yeah, thank you for this opportunity, sir. This is the second time I am coming into the group. Thanks for giving me this golden opportunity to present about ECIRS. And this presentation is a collection of cases from our team, starting from Dr. Devanathan, Dr. Govindarajan, Dr. Maheshwaran, Dr. Vinod Khanna, myself, and Dr. Karthikeyan and Dr. Suresh. So we are a team here. And this was all possible because of the team. So we owe the credit to Dr. Arun from INU Chennai, because he was the one who pushed us to start supine PCNL. So we started doing supine from 2014. Then slowly, once the refinement happened, then the ECIRS started. So this is how our journey of supine, prone to supine, and eventually we moved on to ECIRS. So thanks for giving me this opportunity to share our thoughts on this. Shall we start with the presentation?
Yes, yes. Please share the screen and go ahead.
Yeah. So.
Yeah, visible. Enlarge the screen.
Yeah, it's fine.
Yeah, fantastic. Very clear.
Yeah. So this presentation is going to have a short discussion about ECIRS as such, and I'm going to have a projection of few cases where we decided to go ahead with ECIRS. So let us start with the basic concepts. It is combining 2 procedures into one. This is not a rocket science that this needs special learning and other things. If you are able to do supine PCNL, if you have got the skill set of RIRS, then it is just combining both the procedures to improve the benefit. So this is not something with a unique learning curve, but little bit of orientation is what is required. What are the advantages? Is that we reduce the number of punctures. So previous days, we have seen lots of multi-puncture PCNLs. With adaptation of this ECIRS, we will be able to reduce the number of punctures. We have reduced operating time because two teams will be performing simultaneously. So the operating time comes down significantly, especially in large stone bulks. We have improved single sitting success. So multiple sittings may be reduced. This is a wonderful example to show how a teamwork can bring in wonderful results for the patient. And either it can be decided preoperatively. As soon as we detect some complexity in the stone and the anatomy, we can plan for ECIRS, or at times it can be decided on table into an emergency conversion and proceed to clear the stone completely. Another biggest advantage is that it can be done under spinal anesthesia. To be honest, if somebody questions what is the use of or what is the superiority of supine PCNL over prone PCNL, the biggest advantage is that it can be combined with flexible ureteroscope, making it as a ECIRS. So that is one big advantage of doing a supine PCNL. The only con or the problem here is that you need two sets of instruments, like two operating team, two surgeons, two assistants, and two trolleys and two camera and light sources, and so on. Probably two energy sources, but that may not be needed always. But even if you have a limited setup with one set of instruments, but two surgeons, it can still be done in a very, very comfortable way in tandem. We started our supine PCNL in 2014, and we stuck to our ECIRS only when there was complex renal anatomy. Otherwise, we were very comfortable doing our prone PCNLs. The positioning initially was a bit awkward. We selected a flank-free positioning. The positioning was a bit awkward. Thanks to Arun sir, he convinced us. He improvised his positioning. From 2017 state conference, he designed a different positioning technique, which was more simpler. So for the benefit of the audience, I have got a small video clipping of supine PCNL positioning, which we follow even today. So now, as you see, this patient is being positioned for a left-sided supine PCNL. Not much of tilt is given. The left leg, ipsilateral leg, is kept straight. And we keep a bolster, one bolster below the left shoulder and another bolster below the left gluteus. So literally it is a 3-liter NS. Just we have wrapped it with a towel. It's a 3-liter NS. Some people can use 1-liter saline bag as a bolster. Now the flank is left free, as you can see. So the patient is supported with a bolster below the shoulder and below the gluteus muscle. So the flank is literally kept free. The patient is under spinal anesthesia. The patient is brought to the edge of the table so that we will not have hindrance while maneuvering the scope. So now this is the scope. Now this is the positioning. The contralateral leg is positioned like any other lithotomy position, but the ipsilateral leg is kept straight.
Your voice is breaking. Check the internet connectivity.
Yeah, that's fine, sir. Is it better now?
Yeah, so, little breaking.
I think because of the
voice is breaking.
Video.
Picture I am seeing, but your voice is breaking.
Yeah, now is the voice okay? I have paused the video.
No video. Your voice should come clear.
Yeah. Is
okay?
It?
We are able to.
I have paused the video. So is the voice okay now?
No. You speak. Okay. Video also is important. No? Speak.
So now I'll tell about the markings. The first thing is the posterior axillary line is marked. Then we are marking the 12th rib, and then the iliac, the supine anterior superior iliac spine is marked. So this is how the marking is done. Ideally, the marking should be done with the patient in standing position or in sitting position so that we will not miss the marking. But here, because it was done on a workshop, this was shot on a workshop, so the patient was already under anesthesia. So he's making the marking. So now we are seeing the window, you see one mark is the anterior mark is the posterior axillary line. The posterior border is the OT table per se, and the rib and the iliac bone is marked, and whatever is the central point will be the point of entry. So this will be adjusted based on the patient and little bit of anatomy. Positioning might differ little bit in obese patients, but since that is not the main instance of the talk, I have not have a positioning video for obese patients. Now, this is the OT setup. Now here, this is a right side ECIRS positioning. The ipsilateral puncture supine surgeon is sitting on the right side. His assistant is standing there. As you can see, the RIRS surgeon is sitting in the lithotomy positioning. The nephroscope monitor is kept opposite to the puncturing surgeon. The flexi monitor is kept opposite to the RIRS surgeon. And the CM monitor is kept so that both of us can have a comfortable view. Once the C-arm is out, then everything is slightly reoriented so that nobody has to flex the neck and strain it. The whole point here is you can adjust the OT setup according to your OT dimensions and the comfort of the surgeon. This is another advantage of supine PCNL, where the surgeon sits and operates. The entire crew will sit and operate in both the positionings. Now, this is a combined view. When we do ECIRS, if you are doing the flexi part, make sure you see only the flexi part. Your assistant should see only the flexi monitor. Otherwise, there will be lots of confusions. We had it in the initial days, then we corrected ourselves. So the clue here is the flexi surgeon and the assistant should see the flexi monitor. The supine PCNL puncture nephroscope surgeon should see the nephroscope monitor. For benefit of understanding, I have combined both the views for better clarity. Now the flexi surgeon is going in. Please see the left side of the monitor. There is fiber optic flexi scope with which we are going to the upper calyx. On the right side of the screen, we are seeing the nephroscope. We have already cleared the stone in the renal pelvis and lower calyx. We are going to the upper calyx to see the fragments there. So now with the flexi scope, we are able to see the upper calyceal stone. We have already engaged with the engaged basket. We have basketed it. Now you see, switch your view to the nephroscope view. We are basketing the stone from the basket. So this is passing the buck, where you try to basket the stone from the upper calyx with the help of flexi scope, hand it over to the nephroscope grasper, and it is removed from the nephroscope grasper. Or we can continuously, with high irrigation, we can break the stone fragments will escape and come out through the nephroscope. So if the bulk is too much, then basketing will be quicker. If the bulk is smaller, then lacing the stone itself will flush off all the fragments to the omphlats. So this is the strategy here. This is a complete C-arm reconstruction of a ECIRS. Now this patient has multiple stones in almost all the calyces with a large renal pelvic stone, well dilated system. Now we have decided that we will go with the nephroscope with the lower calyx and then deal remaining things with our flexible ureteroscope. The renal pelvic stone and the lower calyceal stone is over. Now with the flexible ureteroscope, we could basket some of the fragments which were where the infundibulum were open. For some stones which were bigger, like this is in a parallel calyx. If you can notice, this particular stone is in the parallel calyx of our puncture, where unless we make another puncture, it will be difficult to reach this particular calyx. So we could go there, break the stone, and flush out all the fragments. So as you can see, it is only one track, multiple stones, almost all the calyces, large stone burden, everything has been cleared in one single sitting. We could always recollect certain instances where the C-arm has shown complete clearance, but sometimes there will be some residual fragments which will be picked up with the help of flexible ureteroscope, and that can be basketed or flushed off for thorough on-table complete clearance.
That is very, very useful, I must say. C-arm is, whenever we see C-arm and finished, it should not be happy. Definitely few fragments are not seen in any best C-arm. Very valid point.
Now this is another case, similar situation where we have multiple stones in almost all the calyces, large pelvic stone. With this video, I would like to highlight 2 points. Common question that occurs is where to puncture, which calyx should we puncture, which stone to be dealt with the flexible scope. There is no hard and fast rule that this is where we have to puncture, this is what we have to deal with the flexi. Keep an open mind while you plan. There are 2 or 3 tips here. One, wherever there is lots of bulk, it is better to puncture that zone. This is one strategy. The second strategy is wherever you feel the flexi scope will have significant strain, then you puncture that particular area. Where you feel the flexi scope can have a clear access, you take those fragments with flexi scope. So though this procedure was initially designed in our fiber optic era, we started in 2014. So in fiber optic era, we were doing it. So our concern was to safeguard the flexi scope. No TFL was available at that time. We had only first generation or just we had the dusting high power holmium laser. Otherwise, we were having an old generation of laser, which will only do fragments. So our planning was completely different in the initial days. But now we have more flexibility. So don't go with a fixed intention of this is what I'm going to do. Always keep an open mind. Now, this particular video, you will see similar situation to the previous case, but we decided since the bulk of the stone was in the upper calyx, we did an upper calyceal puncture in supine PCNL. Hardly we could have entry into the calyx. We parked the amplats at the parenchymal level, broke and slowly gained our way inside. Now it is time to clear the secondary stones in all the other calyces. With the help of flexible ureteroscope, we went, now this is just to say hi, nephroscope and flexiscope to say hi. As you can see, we went to each and other calyces, started flushing with good amount of irrigation. All the secondary stones started getting flushed out through the amplat sheath. So this technique is called as vacuum cleaner effect, or this is also called as passive clearance. This is another good property of supine PCNL. All that we are only going is, we are doing good amount of irrigation with the flexible scope, and we are going in and coming out with the help of nephroscope. We could clear all the fragments without using any grasper or basket. So this is another handy trick. If you see lots of secondary stones, do not panic. They will get flushed out with amount of good irrigation. I had to mention a trick again here. When you go, already the nephroscope part is over. Usually we finish the nephroscope part first, and then the flexible scope part goes in. When the flexi surgeon goes in, the nephroscope surgeon should take out the nephroscope, keep the amplats closed. That is when the system will be distended. Otherwise, whatever irrigation we give with the flexi, the system will always be collapsed. We will lose orientation of how the intrarenal anatomy is. So the trick is, once the nephroscope surgeon finishes the job, let him take out the nephroscope, plug the amplats opening so that the system is distended. The flexi surgeon will have all the orientation inside, and then he can start his job. Intermittently, when flushing happens, we can take out the finger. The nephroscope surgeon should take out the finger and let out the fragments out, so that we also keep the system partly distended. We also create enough space for the stone to flush out through the amplat sheath.
I want to interfere, Vikram, here.
Yes, sir.
If you do PCNL first and then go with flexi, some amount of bleeding can hamper. If you can get fragmentation and bring the fragments all into pelvis is also a good idea, especially if it is small volume, where you know that you need flexi. The clear vision will be there, especially in post-tented cases, or you do only puncture and keep as vent. Once you do dilatation and manipulate, sometimes flexi person finds little difficult. What is your opinion? Sometimes.
Yes, sir. That rarely that happens, but most of the time, with good amount of irrigation and the coherent work of the flexi surgeon and the nephroscope surgeon, it should be possible to get a decent vision.
Yeah.
The only point is, whether we will do the flexi first and finish the stone and then the nephroscope surgeon comes, it's all personal preferences. There is no hard and fast rule. I would say this is like a modern art where there is no standardization or fixation. This is how it has to be done. This is first, this is second. This is more of a comfort of the team and the orientation that they have. Say, for example, if you feel there is some amount of bleeding, so I always finish the flexiscope first when the vision is good. Well, we'll finish the flexiscope and then do the dilatation and go ahead with the nephroscope part. So there is no hard and fast rule. But the only caution here is if the nephroscope surgeon uses a pneumatic lithoclast, it is always better that the flexi surgeon stands outside. We should never do it simultaneously. Even if the nephroscope surgeon is using laser, if the flexi surgeon is going to cross that part, it is better that the flexi surgeon waits, let it happen in tandem, let the nephroscope part get over, and then the flexi part start. So these are some basic requirements to safeguard our instruments. Otherwise, there have been some instances where the nephroscope surgeon was breaking with the lithoclast, the fragments went and hit the flexiscope and the flexiscope broken. So these things have been documented. So we have to be cautious when we work in coherence.
Yes, yes.
So now we will start with the sequence of cases. I have about 22 images. So we'll discuss one by one where we punctured, why we selected such a patient for ECIRS. Now, this was our very first ECIRS case referred by our good friend. Little complex renal anatomy. This patient also had a left-sided ureteric stone, mid-ureteric stone. So that was done. And then they had done a right lower calyceal puncture for a complex partial stagon on the right side. Unfortunately, there were lots of residual fragments and the fragments had migrated to every nook and corner of the kidney. With this complex renal anatomy, we thought we will do our ECIRS, and this is how our ECIRS journey started in 2014. This was our very first case. Here we selected a lower calyceal puncture and then used flexible scope to clear whatever fragments were remaining in the upper calyx. We broke it and flushed it, increased the intrarenal pressure, and this is when the passive clearance really worked and all the stone fragments were flushed to give complete on-table clearance. Another patient with achondroplasia, as you can see, multiple stones and a little complex renal anatomy, hard stones in the renal pelvis, bifid system, hard stones, multiple stones in the lower calyx and the upper calyx. We did one puncture to the lower calyx. This calyx was punctured, stones were cleared, renal pelvic stone was cleared, did flexible scope, broke the stone into pieces, passed on the buck through the nephroscope, and could give a complete clearance on table in one sitting. This was an unstented system. Another complex renal anatomy, multiple renal calyceal stones, where we actually did a upper calyceal puncture, lower calyceal puncture, and the upper calyceal stone was broken with the help of laser. Unfortunately, at that time, we didn't have TFL, so we had to spend lots of time. But the biggest advantage was because we couldn't basket the stone here. As you can see, the upper calyceal infundibulum was long and narrow. So we couldn't basket the stone. That stone was also quite big. We were initially thinking whether to do another puncture, but with patient breaking, because we didn't raise the intrarenal pressure much, because we had amplats in the lower calyx, we had good amount of flushing effect. So patiently, we took 2 hours to break the stone completely, punctured the lower calyx here, finished the upper calyceal stone with the flexiscope. So another case, unfortunately, 2 lower calyceal stones, both were in parallel calyx. We already made 2 punctures, cleared the stone. Now this starfish was sitting in the upper calyx. So we decided on table to go ahead. Initially, we planned for 2 punctures, one for lower calyx and one for upper calyx. But unfortunately, we had to exhaust our lower calyceal punctures here. And we couldn't access the star-shaped stone through the nephroscope. So we used ECIRS to break the stone and flushed all the fragments to the amplat sheath. Again, complex renal anatomy. As you can see, a large pelvic stone with multiple upper calyceal stones. In fact, this pelvic stone here was flushed in through the upper calyx as we did the RGP. We went ahead, did a lower calyceal puncture, did the pelvic stone, and then used flexiscope to complete the upper calyceal stones.
Yeah.
Here you can see the lower calyceal puncture was used, and flexiscope has been used to see the complete the upper calyceal. 2 stones were there. We could break it. This was our live operative workshop in 2020. This was a diverticular stone, multiple stones inside the middle calyceal diverticulum. Patient also had a renal pelvic stone. So I initially thought we will be able to do the job with RIRS. And I also highlighted during the workshop that our senior colleague, Dr. Govindraj, was saying, no, this will need puncture. But I was very confident of finishing it in RIRS itself. We went ahead, started opening up the neck of the diverticulum. Unfortunately, there was a blood vessel, pulsating blood vessel that was crossing. So we were not ready to cut open that blood vessel. Again, on table, immediately I called Arun sir. He was in the next OT. He came. Everything was done live, on table conversion from RIRS to ECIRS. He could have a straight hit of puncture to the diverticulum, completed it, and then we opened up the neck and placed the stent through that. This patient had live on-table conversion from RIRS to ECIRS and cleared it. And probably that was India's first live operative workshop with 4 cases of ECIRS done on the same day. This is another complex renal anatomy. We did a lower calyceal puncture. There was no way we could reach the middle calyceal stone extension through this. We used flexible ureteroscope to go to the middle calyx for a complete 1-stage clearance. Another complex renal anatomy, a bifid system with multiple lower calyceal and upper ureteric stones. When we go with the puncture and ureteroscope, there are chances that the stones might migrate to the upper calyx, upper moiety. It was a bifid, partly bifid system. So we selected for ECIRS, punctured through the lower calyx, and those stones which ran into the upper calyx was broken and basketed with the help of flexible scope. Again, similar situation, multiple ureteric stones. We made a puncture, again bifid system. We could give one sitting on table clearance. These stones, we did a lower calyceal puncture and accessed whatever secondary stones ran into the upper calyx, we could access with the flexible scope. This patient, this was done during the peak first lockdown of COVID, multiple ureteric stones. We did one puncture, took out the semi-rigid ureteroscope, and we went with the ureteroscope. All the stones we increased the ureteric pressure, and slowly the stones one by one, once we removed it through the nephroscope, we started flushing. All the stones got migrated to the renal pelvis. With the help of passive clearance, we could give on-table clearance with one single sitting under spinal anesthesia. This is another COVID patient presented with sepsis. Patient had one renal pelvic stone and one lower calyceal stone. PCN was placed under local anesthesia, and then when the patient was stabilized, we used the same track to go and do the pelvic stone with the nephroscope and use flexible ureteroscope to do the lower calyceal stone.
The flexible scope could go easily?
Yeah, it could go easily, yes. It was unstented system, but most of the time before we started using the HugeMed 7.5, unstented systems, we used to take our FlexX2 because that was like any other primary RIRS. So we could comfortably take in that 7.5 French scope. So now this is another complex renal anatomy. The ureter was merging somewhere close to the mid-ureter. There were fragments in the upper calyx. There were fragments in the lower calyx. And lower calyx also, multiple calyces were there in the lower component. Puncture the lower calyx to clear this component and use flexible scope to go for the upper moiety. Another complex renal anatomy, as you can see, already 2 punctures were made. There was some more stone in the upper calyx. This stone was there in the upper calyx. Use flexible ureteroscope for complete clearance. Again, this is an elderly patient with lots of comorbidities, multiple stones. The left side was planned for staged RIRS in the future. Right side was planned for puncture. Had raised renal parameters, so we couldn't do a contrast study pre-operatively. All we had was an X-ray and a plain CT KUB. And On-table RGP showed complex renal anatomy, multiple long, narrow infundibulum leading to calyces. So there was stone here, there were stones here, there was stone here. So we did a puncture to the upper calyx. All that we had was space for especially this calyx was little difficult to puncture. Exactly, we had a space only for a 16 French amplats. We cleared the stone, and then we used the flexible ureteroscope to finish this fragments. This one and this one was completed with the help of flexible ureteroscope, and the fragments were flushed. Could give one stage on table clearance. Another complex renal anatomy, as you could see, lower calyx has been punctured, and there was stone here in this calyx. The flexible ureteroscope has been used to clear that. Again, here a little bit of impacted stone. We thought we will have good amount of torque when we come out through the lower calyx. From here to here, we thought we will have difficulty. So we thought we will have upper entry through the middle calyx. Here we had an entry through the middle calyx, finished the large impacted pelvic stone, and then took the flexible ureteroscope to clear the lower calyceal component. So here it was a middle calyceal puncture, pelvic stone was cleared, flexi was used for lower calyceal stone. Another complex renal anatomy, lower calyx was punctured, upper calyx stone was used for with the flexible ureteroscope. I think Chandramohan sir has had a few videos of difficulty of puncturing medially facing calyces. Upper medial is a very difficult calyx to puncture. Here we used the lower calyx to puncture and clear. Upper medial calyx, there was a large stone. We finished with the help of flexible ureteroscope, could give a complete clearance. Here also you can see long, narrow infundibulum. Very difficult to puncture this. Another option was to puncture through this and go here to clear the stone. But we could avoid it by using a flexible ureteroscope and combining it with ECIRS. Another biggest advantage of ECIRS or supine PCNL is that we can have something called as a flexi-guided puncture. Sometimes we will be left in an awkward situation, especially in lower calyceal stones, where the stone will be in one lower calyx. Unfortunately, we would have punctured the anterior calyx, that is the contralateral, that is the opposite calyx. Probably the stone will be in the posterior calyx. We would have punctured the anterior calyx, and we would have dilated the tract to go in to see there was no stone. Unfortunately, we don't have a 3D image with the C-arm, so this will come in handy. Once you have a complex anatomy, we have little bit of confusion. We can always use the flexible scope, go and stand in the desired calyx, allow the PCNL surgeon to make a puncture, ensure that he is puncturing the right calyx, and then dilate the tract to go in. So this is a simple video. This is also done in one of the workshops where Chandramohan sir was there. You can see the stone in this particular lower calyx. Now the puncture has been done through the desired calyx. We have confirmed that he has shown the entry through the C-arm also. So now the guide wire was passed, and then the dilatation was done to clear the stone. So flexi-guided puncture is another handy trick in awkward situations. This is another trick. Till today, we don't know how this happened. We have a large renal pelvic stone. This stone seen in the upper calyx was actually in the lower calyx. We made the position. We thought it's going to be a simple, straightforward puncture through the lower calyx. Unfortunately, once the dilatation, everything was done, the contrast was injected, the lower calyxial stone migrated to the upper calyx. Now, this is a long, narrow infundibulum leading here. We entered through the lower calyx, finished. This was all on-table conversions. We finished the renal pelvic stone, and then the ureter was tight. We couldn't take the flexible ureteroscope. So since this was a digital scope, we used our digital flexi scope as a nephroscope, entered through this curvature, and with TFL, we dusted and gave a complete clearance. So this is just out of the box thinking. If you don't have a flexible nephroscope, still we can consider using our flexible ureteroscope as a replacement for nephroscope and give an on-table clearance in such situations. Another COVID patient. This patient presented with sepsis, a female patient. We did a stenting under local anesthesia, and we went ahead thinking that we'll do RIRS and clear the stone. After a month, we went in, and to our surprise, we realized it was a bifid system. Now the contrast is put, the system is somewhere else. We were unable to find out where this next ureter was going, leading to the lower moiety. So we did an ultrasound guided puncture to the stone, put some injected contrast to confirm that we were in, did a dilatation, finished the PCNL, and tried to pass a guide wire. Now the guide wire was not going in because wherever the moieties were meeting, that area was narrow.
Yes.
So as you can see here, we see the guide wire was coiling here. We were unable to get the guide wire across. Now we used the flexible ureteroscope for antegrade RIRS. So we used the flexible ureteroscope, went in, saw exactly where the confluence happened, passed in a guide wire through that, and we could stent the system. The patient has come for second year follow-up. She is doing perfectly fine. No recurrent stone. Now this is another complex renal anatomy with upper calyceal stone and lower calyceal stone. Puncture has been done for the lower calyceal stone. Flexi part has taken care of the upper calyceal stone. This was recently done in the Stone Fest by Vaddi sir and Dr. Karthikeyan, where it was done as RIRS. Unfortunately, this image is not clear, where this is also a bifid system with the stone partly projecting into the upper moiety, partly projecting into the lower moiety and into the ureter. So they made a puncture into the lower calyx to access and finish it off, used a flexible ureteroscope to finish the part that was protruding into the upper moiety and the secondary stones in the upper moiety. Everything is not rosy. We have had our own failures with ECIRS. This patient presented with multiple stones on the right side and multiple impacted stones on the left side. Right side, I did an open extended pyelolithotomy because it was a properly functioning kidney. Opposite kidney, the left kidney was not functioning well. So we planned for a staged ECIRS. After clearing all these stones on the right side, we went ahead with the ECIRS for the left side. Unfortunately, we were lost. The anatomy was lost. It was impacted. The mucosal overgrowth everywhere. The nephroscope surgeon as well as the flexible ureteroscope surgeon was, we were completely lost. So whatever optimum clearance we could give, we gave, and so many stones were remaining. And this patient is also on follow-up for the last few years. Now the take-home points, ECIRS is a very safe and handy procedure. It needs proper planning. There is no hard and fast rule. The puncture can be planned considering various factors like a stone bulk and the ease of access with the help of flexible ureteroscope. Sometimes we need to have out-of-the-box thinking, and it certainly has its role in complex renal anatomy. If you had seen all these 22 cases, most of them would have had complex renal anatomy. So it is handy. The only issue here is you need two teams with proper coordination. If you are not coordinated, then definitely you will struggle on table. Otherwise, it's a very, very straightforward procedure. Thank you.
Yeah. Vikram, thank you for nice presentation, good cases, variety of cases. Let's have discussion for 10 minutes. I will ask quick questions.
Yes.
If one PCNL surgeon says that if ureter is not dilated and if you cannot access the flexible scope, how can you say that ECIRS in that case?
So there are two things. If it is going 80%, if anybody doing regular RIRS would accept, the 80% of the times we will be able to do primary RIRS.
Yes.
So we will be able to do primary ECIRS.
Of the cases, they ask whether you do PCNL and then postpone the RIRS, or you put stent and entire procedure you stage later on.
Again, it depends on what sort of a complexity has led to this. There is no hard and fast rule. If we have already planned for a puncture, I would personally finish the nephroscope part, finish the puncture, probably even consider second puncture and finish it off, or use the flexible nephroscope or a flexible ureteroscope to clear the remaining stone. In case we are unable to do, I will finish the nephroscope first and have the relook RIRs first as a secondary procedure, as a staged RIRs.
How many years you have done prone PCNL?
5 years post MCH.
How many years you have done supine PCNL now?
Now 9th year going on.
9th year going on. So, what are the conditions where prone PCNL you may think once?
Pardon me?
What are the conditions where after seeing the CT, IVP, X-ray, you think that this may be easy for prone? Do you have anything in your mind? Honest.
Not as such.
Yeah.
Because there has been no instance, probably at least in the last 5 years or 6 years amongst the team members, where we had to try supine and then convert it to prone. Yes, the situation has happened during our learning curve because we were more trained in prone PCNL and we were more comfortable. But once this refinement of position happened, once the whole team was oriented towards the supine puncturing techniques and dilatation techniques, then things became easier.
In fact, one condition, incidentally, today only Dr. Hemnath from our other center asked, horseshoe kidney is there, ureteric stone in the opposite side. He wanted to do prone. I said that try supine. There is no harm. Both mechanisms are same. Just now he shared while I am on the talk that he did supine and he did opposite URSL while doing the prone PCL, that is SBES. That means even anterior mal-rotated kidneys or medial superior kidneys with experience can be done.
Yes.
But juniors, upper calyxial puncture, they say that supracostal medial cannot be seen through the supine PCL position, which is not correct in my opinion. What is your opinion?
True, sir. I also don't agree with that concept. There are only 2 or 3 difficulties I would like to highlight in supine PCNL. When somebody is migrating from prone to supine, 2 or 3 difficulties they could encounter. One is while dilating the tract.
Yeah.
During prone PCNL, the kidney is fixed. But in supine PCNL, the kidney is mobile. So the more they try to push, the kidney will also keep moving. That is one difficulty when somebody who is starting new might encounter that. That is countered by having another hand in the opposite side, countering the movement and then dilating with the right hand. That will be done. That will be encountered. One instance, even with that maneuver, we couldn't help. So what we did a semi-rigid ureteroscope, took it, fixed the kidney with the help of semi-rigid ureteroscope. The semi-rigid ureteroscope went up to the upper calyx, fixed it there, and then did the puncture and dilatation. Everything went on smooth. So mobility of the kidney is a challenge in supine PCNL.
2 questions are asked from Abhirup. Which surgery can be done if stone is there in the calyx and pelvis of the kidney? I'm not getting exactly what he wanted to ask. As you said, if anything can be removed large volume with one puncture, ideally avoid ECIRS, finish in supine PCNL. No need of unnecessary 2 monitors, 2 surgeons, 2 equipment. It is costly. Vivek Punuganti has asked, did you abandon any procedure after ECIRS also? I mean, not able to continue ECIRS and stopped it.
Yes, that has happened. Like the last slide that I made, I just wanted to make a point that there can be instances where you are lost in the anatomy, you don't know what is happening, bleeding happening, everything is impacted, mucosal bleed is happening, abandon and come out. See, ECIRS is done to improve the safety and improve the clearance and make the surgeon and the patient's life comfortable. So let us have our own markings there. If you are finding it difficult, there is always another time. Stent and come out, we can always go in again.
When you put a patient in modified Valdivia position, especially when the limb is less flexed, when you do ureteroscopy, the ureter appears more lateral and ureteroscopy rigid may be difficult. So will you put access sheath in normal lithotomy and change quickly the position, or you don't feel only one position is okay? I hope you are understanding my question.
Got
If
your
you do
question.
lithotomy, you need to change the drapings. Then prone surgeon says that much draping change anyway we also will do. Then why should we put? So as such, we are not changing the position. With experience, we are able to pass the guide wire and access sheath also. So a little difficult. What is your opinion?
Yes, sir. Especially in well-built patients with nice thick psoas and well-built patients, we may have difficulty in taking the semi-rigid ureteroscope, but we have never had a difficulty in placing a access sheath or to take the flexible scope. For
If
that
the
matter,
guide wire goes, job is done.
job is done. For
Job
that
is-
matter, even in prone PCNL, George P. sir will do the cystoscope part in the stretcher.
Yeah.
Not even lithotomy position. In supine position, we will do the cystoscope part to place the guide wire and uretery catheter and just rotate the patient to the prone position.
Yes.
So that is not a challenge.
Not a problem.
There have been some instances where with stiff joints, we find the working space limited for the flexi surgeon.
Are you doing supine PCNL under spinal anesthesia?
Always.
Always. Are you not? What is the tip and trick when you do interspinal for puncture? Will you say patient stop a little bit respiration or not much necessary?
Again, that depends how mobile the kidney is. If the respiratory movement is too much, we ask the patient to hold the breath for the puncture or for the dilatation. If the kidney is not that mobile, patient is very calm and he is just having a very controlled respiration, there is no need. And I would like to highlight already our presentation as... Pardon, sir?
When we asked the Alken, Peter Alken in Hyderabad in 2009, how do you puncture in a moving kidney? He says that when you go to toilet, when you pull the toilet paper, it will be coming continuously, but you have to pluck it out fast so that it breaks. So you have to puncture that moving kidney in a short period of time so that it goes into the calyx. After that, it will not move. You are understanding what I am telling?
Yes. Another point is,
Vikram?
Yes, sir. In supine PCNL, we go very gradually. First, we puncture the parenchyma. Now the parenchyma gets fixed. And then only we maneuver into the calyx. So that mobility issue will be addressed marginally in that. But sometimes we ask the patient to hold the breath.
If matrix stone is present in different calyces like a staghorn, does ECIRS has any role? A very good question asked by Sandeep.
Definitely.
ECIRS has any role?
Definitely, yes. Because the whole point in matrix stone is that we will not be able to break it into pieces. We may be able to break the shell, but not the core.
Yes.
So here what we can do is we can use the pass on the buck technique. We can basket the matrix and give it through the basket.
Basket gets the matrix so easily? Difficult.
Yes. Engage basket will do the trick. If you use encircle basket, that may not happen. Engage or the G-POW basket, which will act like a grasper, but it is a basket. So that will, you can just hold the tip like holding the rat with the tail. Hold the tip, basket it, give it through. We have done ECIRS even for large necrosed papillae.
Yeah. Necrosed papillae is a little different. It will hold with the basket very well. But sometimes matrix will break up. When you bring it, it will be breaking up.
All the more we'll flush it out.
It needs some patience. You need to be patient. And for me, somehow, this is the only point I am differing. For me, if I have any doubt that large matrix is there, I will do second puncture, third puncture, suck it out. Because these matrix stones, if you leave something inside, they grow very fast. There will be some fungal or mixed bacterial infection. Completely clean the kidney. For all practical purposes, even shortest ampulla sheet 15 can do better job than the RIRS. So that's my version. But if it is a small speck, small pieces, bring it down and get it. That is very good.
Yes.
Ask a few questions. Supracostal. How far you have gone in the supine PCNL? Which puncture? Did you ever go on about 10th rib? Do you think that the deep respiration will help in supine PCNL?
Yes, deep respiration does help, but I have never gone above the 10th rep. If similar things happen, I prefer to do it in staged RIRS rather than to take the chance of supracostal punctures.
With the presence of the high wattage lasers, TFL, 60, 100 watts chromium lasers, doing fragments and getting fragments into the pelvis is not a very tedious job. If you want to make powder, it is okay. Once you get into pelvis, whatever the nephrostomy tract you have, they can be sucked out easily. So very quick work can be done. Temperature raise will not be there. That is a wonderful indication where if upper calyx is going up the 10th rib bifid system, and if you have a lower calyx stone or no stone also, you can get away by avoiding the supracostal puncture, which is harmful either way in prone PCNL or supine PCNL. My last two questions. When you started supine PCNL, that should be honest answer. When you start supine PCNL, first 10 cases, what are the 3 important horrible points you missed? Later on, you thought that, why I have done like that? What are the 3 tricks, very important tricks you wanted to mention when you do the supine PCNL in first 10 cases? Of course, now people are watching videos, people have opportunity for the internet. But sometime when you have started, I have started, we did not have that much videos. So what mistakes we commonly do? 3 mistakes.
One, marking.
Yeah.
Most of the time, we will anesthetize the patient and then start marking. This is okay for thin or reasonably moderately built patients, but not good for obese patients. We will 100% miss the markings in obese patients. That mistake we have done. So it is always better to do the marking first, even before we make the patient lie down on the table. This is one important trick I wanted to communicate. Second trick is mobility of the kidney. Especially in obese patients, we will find it very difficult to fix the kidney while dilating. We'll get the puncture, the guide wire will go in. But when you take the dilator, the kidney also will keep moving. So there we need some patience, some presence of mind, the assistant to put his hand or to use any other means. Recently, we saw one tweet where they had done another puncture in the middle calyx to fix the kidney and then dilate the tract in the lower calyx. So some out of the box thinking to do that. Third one is positioning. Our staffs are quite experienced, but they have done terrible mistakes in positioning the patient. The patient should always come to the corner of the table. So that is why even during the positioning video, I insisted. We have done that mistake in the initial part where the patient will be here and then tilted, but the patient would have gone to the middle of the table. Puncture done, tract dilated, nephroscope will hit the table, OT table. So make sure once the patient is tilted, he should be brought to the end of the table so that the nephroscope doesn't hit. These are all small technical, logistical issues, which was subsequently overcome.
Last question of the day. In prone PCNL and supine PCNL, is it necessary that C-arm has to come from the opposite side? Can it come from the same side? Both surgeries, with your experience, answer wisely. Again, asked by Vivek. It's a very good question. In fact, if you have any theater congestion, if all the equipment are on the other side, suddenly you wanted to bring, can C-arm be brought in prone and supine from the same side?
Yes, it can be done. In fact, I was trained for PCNL with George P. Sir, who used to have the C-arm on the same side.
Yeah. So answer is yes. There is no problem as long as your body is not interfering with the body of the C-arm. If you can adjust that way, your puncture or your movements for the stone, later on you can move a little away. Once you are inside, you stand away and do it. More easy in supine PCNL, little difficult in prone PCNL, because prone PCNL you will go closer to the patient shoulder and C-arm may hamper, whereas in supine nicely half meter you can go away and do puncture with your body away and only your hands nearby. So in both the conditions, C-arm on the same side can be done, but I have a doubt that radiation may be more if you keep on the same side. I have to confirm, because your body will be close to the it comes from your side and goes inside, chances of your side rays coming more to your bottom are more. So that is my feeling. So thank you, Vikram. Excellent answers.
Thank you, sir.
excellent discussion. And I must appreciate your teamwork. Continue teaching and continue learning. And you are the team which is helping a lot of the juniors, not only in Tamil Nadu, but other states and other parts of India also.